feel really comfortable interrupting me, please. And hopefully we'll have some time to engage at the end of the presentation. The work that I'm bringing to you today is really around arteriopathies of the aorta and the branch vessels with a real concentration on renovascular hypertension. I want to share a little bit of what we're doing with our global PCORI-funded collaboration now that is open to both clinician, researcher, but also patient and family stakeholders. And I'm also happy to share some of the work that we're doing with our Society for Vascular Surgery, which I think offers a lot of opportunity for educational means for providers of kind of various ranks, both learners in residencies and fellowships, but actively practicing vascular surgeons, just to kind of learn about more, think about more, and work together with some individuals that are also thinking about these rare pediatric vascular patients. We're going to be coming together with a quarterly cadence. And I'll talk about that a little bit as well. And so I do think there's very meaningful opportunities for international collaboration in this space. And you'll hear me say a couple times throughout the course of this presentation that I'm confident we can do a little bit better, really a lot better for these children. So with that, I'll start, and I'll just make sure that these work again. I just want to propose that I do have a few disclosures that I think are relevant. The first is that I am the project lead of the PCORI-funded collaborative I referenced. The second is I only recently made a transition away from the University of Michigan. But I left, I think, for an opportunity that was really hard to turn down to lead a team at Duke University and really serve a swath of patients in the South that need improved access to care. And I left the University of Michigan really on intentionally good terms. I wasn't running away, and rather importantly, I've maintained an adjunct appointment and continue to collaborate both clinically and academically with that team. I also get an honorarium from an up-to-date chapter that's not relevant to this presentation. And I wear two relevant leadership hats as an officer within the Vascular and Endovascular Surgical Society, where I serve as secretary and the president-elect for our Association for Program Directors in Vascular Surgery. But I want to start this conversation today and this story by talking a little bit about teams. So I think the reason I got recruited to Duke is so that I can build teams. And I've walked into a group where there's been a lot of siloed practice patterns and a lot of opportunity to collaborate across disciplines in a way that optimizes patient care and also educational training for our learners at different levels. And this concept of teams is really important. And this is the kind of pathway, the tunnel at the Michigan football stadium where the football players all run, you know, from their locker room to the stadium green field. And it's this very iconic runway, because one of their past coaches, who's really legendary in Ann Arbor, Michigan, would always say the team, the team, the team, right? Like nothing matters about you as an individual if the team isn't performing. And that's really all that matters. And I think that matters particularly in this patient population. And in general, I think healthcare is most effectively delivered by high performance teams. And that statement is founded on a couple really important principles. The first is that exponential advances in scientific discovery and evidence-based practice, along with the increasingly specialized diagnostic strategies and therapeutic options and continued subspecialization, really mandate diverse perspectives and interdisciplinary care. And I think that's really highlighted in these unique pediatric patients. And additionally, teams with their collective skill set, their lived experiences and judgment, they're often more effective than hierarchical or bureaucratic forms of healthcare delivery in terms of efficiency and quality of care for patients. And so my plan and my intent today is really to share a story with you, in part around my own serendipitous pathway or journey in caring for these patients with such a rare disease, but also in how we've built a team, now a meaningful international team that's come together to really advance the care for not just these patients, but their families, by also advancing our understanding of the disease process and treatment options. And so with that, I'll start with a pretty striking phenotype. And there are a lot of case-based scenarios that I'll share today. And my ask is that you please don't populate patient images onto social media. For some of these patients, I absolutely have permission to share, but it's been my own personal practice not to put this out there into social media. for a variety of reasons. But that's my singular ask from all of you. These are images from an infant. So this is an 8-month-old that was transferred from the Pacific Northwest across the country to Ann Arbor, Michigan, a PICU to PICU transfer from the ICU. And she was the product of a 39-week uncomplicated pregnancy. She was delivered by C-section. She was small, in the 19th percentile for both height and weight. And on clinical exam, around 8 months of age, Mom noticed that her lower extremities looked cyanotic. They started almost just very quickly looking rather blue. So she took her to the primary care doctor's office, where she was noted to have relative upper extremity hypertension. She had very weak femoral pulses. She had mottled bluish purple hue of her legs. Her legs were cool. She had a decreased cap refill, and she had a pretty striking systolic ejection murmur. And the workup that ensued included an echocardiogram that revealed severe concentric left ventricular hypertrophy. And then her CT scan shows the following. She has this coarctation with an aortic occlusion of her abdominal aorta just below the left renal artery. And you can see also, see my arrow here, that the left renal artery is narrowed and the SMA is narrowed at its ostia. And this cross-sectional view shows, again, this ostial left renal artery stenosis, and importantly, this teeny tiny right kidney that's atrophied and essentially is without enhancement or flow. And so we attempted to manage her medically, in part given her young age, her small size. And at one point, she was on 5 oral antihypertensives along with a nicardipine infusion. And we were able to achieve modest but inconsistent control of her hypertension. And essentially, when we dropped her systolics below 120, she developed what we thought was intestinal angina. She'd get abdominal pain and bloating, and she'd also develop transient azotemia. And her creatinine peaked at one point to 1.54. Ultimately, she became hemodynamically unstable over the course of about 3 weeks. She had progressive cardiopulmonary failure. She was required to be intubated and was sedated, and we essentially were put in a position where I'm so sorry, there's some annotation right now on my screen that's just started that is making it so that I can't switch my I don't know what's just happened. Asked me to approve an annotation, which I think came from you guys, but now I can't move through my slides. Do you have suggestions?
Tapish, can you sort it out?
In fact, I've completely lost my cursor, and there's a new toolbar to annotate, and I don't know where that came from. Let me see. I'm going to escape. I'm totally frozen here. Oh, it went away. 1 second. Did that work? Yeah, that went away. A procedure that entailed an aorto-aortic bypass, which you can see here. This was performed with a PTFE conduit, oversized in part for her future anticipated growth. So this was about an 8-millimeter graft. You can see her SMA and her celiac artery here. We reimplanted her left renal artery onto this terminal stump of interrupted aorta so that she's getting retrograde flow into that left kidney, and we took her right kidney out. And she did really beautifully. She had an uneventful postoperative day course. She was discharged on day 18 on a single agent for blood pressure with a normal creatinine. And at 1 year, she was thriving. She was in the 86th percentile for weight, otherwise doing extremely well. Her heart had remodeled by echocardiogram. Her MR showed a reassuring reconstruction. And I show this picture from the time of her operation simply to highlight the transverse supraumbilical incision that we use in the infants and young kids. This allows you wide access to both pericolic gutters and the retroperitoneum for renal reconstructions and advanced distal exposure. You also can get surprisingly high on the supraceliac and frankly kind of distal descending thoracic aorta through this exposure. And this is her now. And so she's grown substantially, and she is now on 2 drugs for hypertension, but you would never know that she had such a challenging phenotype that was mitigated so early. And she may, in fact, go on to need future reoperations, but for right now, she's really thriving. And this was taken during our 2nd International Symposium on Renovascular Hypertension, which we hosted at the University of Michigan's football stadium, and kind of site resources and locations the week before I relocated to the South. A few other, I think, relevant case scenarios that I'll kind of breeze through quickly. This is an 8-year-old who's got a history of renovascular hypertension. And about a year prior to us learning about this case, they had attributed the hypertension to an atrophic right kidney. So the child had underwent a nephrectomy, but the blood pressure did not improve. He then developed an upper respiratory infection. And around that time, which is a really classic kind of clinical scenario where the inflammatory response that ensues following a viral respiratory infection, it really exaggerates the hypertension. And so this patient presented with hypertensive urgency, requiring an escalation of his antihypertensive regimen with 5 drugs, also a nicardipine infusion. And he went on to have oliguric acute kidney injury, requiring dialysis. And so this patient was referred for an aortic reconstruction consideration so that he could be a transplant candidate. And we transferred him from, this was an international referral. We transferred directly to our pediatric ICU, and our angiogram showed a couple things. And I think the most important thing is that this left renal artery, which was presumed to be occluded, had an osteostenosis, but pretty robust retrograde reconstitution of a very normal looking mid and distal kidney artery. And so we thought it was worth an attempt at revascularization to salvage renal function. And so that's what we did. We performed a patch aortoplasty of this coarctation. This is the completion angiogram following the surgery. We also revascularized the patient's renal artery. And so you see this reimplanted left renal artery here. And this patient actually did very well. He was discharged on 3 drugs. He had renal recovery at 4 weeks post-op. He went home off dialysis and had further de-escalation of his antihypertensive regimen. And here's another example, a 5-year-old with long segment thoracoabdominal aortic occlusion. And I show this picture just to highlight the robust collaterals these children have that allows them to reconstitute lower extremity flow. This 5-year-old had essentially kind of exertional fatigue in her legs, but really no claudication. 3-drug hypertension that was poorly controlled, left ventricular hypertrophy, and she was treated with an extra anatomic ascending aorta to aortic bypass. She's one of the few exceptions in which her kidney vessels were quite normal. We did really nothing short of revascularize her aorta, such that retrograde filling revascularized both of those kidneys. And she left with a single antihypertensive agent, well controlled, and was doing extremely well several years out from surgery with resolution of her leg symptoms and her LVH. And finally, a 14-year-old with neurofibromatosis and 2-drug hypertension. Really, the indication for surgical intervention in this patient was this complicated multilocular set of saccular renal aneurysms that were downstream for an occlusive stenotic lesion at the ostia of the left kidney. And you can see it's occlusive because there's no reflex of contrast around that catheter. This patient ended up having an ex vivo reconstruction where we resected the aneurysms. We syndactylize these 3 outflow branches into a common ostia. And then we harvested hypogastric artery from her deep pelvis and performed essentially this aorto-renal bypass to those syndactylized vessels. And this is her completion. So I show this set of images that overview the renin-angiotensin system, not to dwell on the science or physiology behind renovascular hypertension, but essentially to share that when there's a stenosis of the aorta or the renal arteries, it decreases the blood pressure to the kidney. It sets up this hormonal cascade, which elevates the systemic blood pressure by a variety of mechanisms. And it is classically medically refractory. And so importantly, it's really not unusual for patients to be hypertensive despite a 5 to 6 drug regimen. Now, we know that occlusive disease affecting the renal arteries ranks as the 3rd most prevalent cause of hypertension in kids. That's behind parenchymal renal disease and coarctation of the thoracic aorta. The exact incidence as the cause of secondary hypertension is unknown, but it's thought to account for about 8 to 10% of those children exhibiting marked blood pressure elevations. We also know that about 40% of patients may have an underlying genetic etiology, and that risk is enhanced in the children who have mid-aortic syndrome. NF1 I've already kind of hinted at or referenced. We'll talk more about this particular syndrome, but elastin variants, Williams syndrome, the tuberous sclerosis genetic variants, JAG1, fibrinogen 1, Turner syndrome, Alagille syndrome, these kind of genetic variants and syndromes have all been associated with renovascular hypertension. I think it's also important to recognize that delays in diagnosis are super common in children, in part because most are asymptomatic, but there does seem to be in practice a bimodal distribution of presentation around age 3, which is the time that most kids will have their first well-child blood pressure check in the United States. And then the second spike being during sports physicals later in childhood. Blood pressure screening is not recommended in those less than 3 unless they have an associated risk of underlying congenital heart disease or intrinsic renal disease or urologic malformations or hospitalization. And the definition of hypertension in kids is essentially greater than the 95th percentile for sex, age, and height, but it has to be on 3 separate occasions. And what we hear from our stakeholders often is that kids will show up, especially early in life. They get angry when they get their blood pressure checked and they get agitated, and people will chalk that hypertension up to agitation or white coat syndrome in some of our teens. And the blood pressure levels are really not followed up. And so often there are kind of hints or suggestions of hypertension where the measurements just aren't kind of believed or trusted by the provider. And so that is a theme that we're working to follow up with our collaborative. Now, mid-abdominal aortic syndrome often contributes to renovascular hypertension in kids. This is best classified by its most cephalad extent of the aortic narrowing as it relates to the renal arteries, whether that's kind of suprarenal, interrenal, or infrarenal. And mid-aortic syndrome is thought to arise from embryonic overfusion of the paired dorsal aortas during the 4th week of development. And in cases of mid-aortic syndrome, what we see is the renals are almost always 90% of the time narrowed. And the splenic arteries can be narrowed in about 2/3 of cases. Additionally, we can see multiple renal arteries. And so the most I've seen is 5 renal arteries bilaterally. And we also see these aberrant lumbar arteries commonly where there's either a shared common trunk with a bifurcation or segments of aorta where the lumbar vessels are missing. And we think all of those things kind of support further this developmental misadventure during kind of embryologic development. Now, medical management is favored for the very young with the realization that definitive surgery is going to more likely be successful in older and larger children. And that's for a variety of reasons, in part with anticipated growth, but also acknowledging that technically these revascularizations are challenging given small vessel size and the vasospasm that ensues for almost all of these reconstructions. Indications for surgical intervention that we've adopted include medically refractory hypertension, which means inadequate control despite 3 drugs that are appropriate, which means they've been trialed and failed an ACE inhibitor or an ARB, either because it hasn't been effective in treating the hypertension or it's caused an acute injury. In addition to progressive renal insufficiency, cardiomyopathy resulting from concentric LVH, hypertensive encephalopathy, which we can see in failure to thrive, which is not uncommon in the very young. Very rarely we'll see lower extremity ischemic sequelae that can include growth disturbances or exertional fatigue and mesenteric angina. And these, when present, justify operation, but they're so infrequent. The other thing I'll comment on is the role for endovascular therapy. And this is where I probably have another disclosure to make, and that is that I have my own anecdotal bias because so much of what we saw at Michigan for a long time were these endovascular failures. And so I'll say it now and I'll say it again in a few slides. There is a role for endovascular therapy in these kids, but I think that's with some considerations. And I just want to introduce a couple concepts that matter with endovascular failures. And so this is an 11-year-old patient that presented with a failed angioplasty. And that angioplasty was treated with a stent. You can see this really long stent that extends into the aorta and really is never fully expanded. And this child essentially ended up having progressive hypertension that was worse post-angioplasty and stenting, for which he was referred for a salvage procedure. And that was performed by way of a stent explantation and an aortorenal bypass to that distal renal artery using hypogastric artery. And this child did well with renal salvage. Here's another pretty severe phenotype. This was an 18-year-old that was referred out of state. She had had single drug, so 1 drug hypertension as an 18-year-old. She underwent angioplasty for that, and the angioplasty failed. and they offered an early stent, and you can see that stent clearly failed. She had progressive hypertension. She was referred to us with 3-drug hypertension, blood pressure that was really poorly controlled, and we similarly explanted the stent. And instead of needing to bypass her, you can see this really short renal artery. We were able to mobilize that left kidney enough for a simple reimplantation. And so we chose to look in 2016, we published our series of remedial surgery for failed endovascular therapy that had come from about 24 kids. We learned a couple important points. The first is that the failures were mainly related to restenosis, and on much less common occasions, true intravascular thrombosis or rupture. And the time to failure was actually really quick. And so it was almost invariably less than 2 years. And we also found that our remedial operations were made significantly more challenging than, for example, an index operation would be. And so I guess what's probably important from this slide is that we were able to achieve renal revascularization by way of a reimplantation in 13 kids, but 10 required a bypass. And as I'll show you in future slides, we really favor a reimplantation when possible. And so the fact that this was split with almost complete equipoise suggests we were doing far more renal bypasses than we otherwise would. We also performed 7 nephrectomies in 24 kids, and that rate's extremely high. Our postoperative hypertension cure rates were only 24%, and we had 16% unchanged. And that also is a blunted hypertensive improvement in comparison to de novo procedures that you'll hear as I move through the rest of our story. So we found the risk of nephrectomy following PTA with stenting was about 30% compared to those kids that just had undergone an angioplasty that failed. That risk of nephrectomy was only 15%. And we found that failures in endovascular therapy in kids aged less than 10 years of age resulted in the highest nephrectomy rates at 44%. Angioplasty and stenting complicated the remedial surgery, again, making it more complicated in over 50% of patients. But we did find in our surgical cohort no major morbidity, operative mortality, or late deaths. And so I'll propose that endovascular therapy, I think, at multidisciplinary high volume centers actually can offer a real bridge in some of these much younger kids to allow a little bit of growth. And importantly, if you could get the blood pressure improved, not cured, but even improved so the heart can remodel and you're not dealing with a child open, surgically speaking, with severe LVH, that optimizes potentially their perioperative course when a more definitive surgical reconstruction can be delayed and performed. And I'll share with you some histopathology, but the small vessel size and the fibrotic nature of these developmental osteostenosis really limits, I think, the endovascular utility and durability. And I personally feel very strongly that there is no role for routine arterial stenting in children, at least right now with the current technology that we have. And so acknowledging that endovascular data and having been trained by Jim Stanley and knowing his data in which he had cited in past experiences cure rates of 70% that my partner, John Elias, and I were just not meeting, I was concerned that either we were inadequate surgeons or my sense was that our patients were, and that perhaps some of these salvage procedures were blunting some of our kind of metrics that we would consider for successful revascularizations. And so with that, we really attempted to understand our more contemporary surgical practice, really in a way to identify or define the increasing complement of complex patients, both with mid-aortic syndrome and failed interventions, and also try to understand some of the prognostic factors that would influence maybe hypertensive benefits or other risks associated with surgery so that we could better counsel our patients and offer them more meaningful shared decision-making around the role for open surgery versus catheter-based procedures versus medical management. And so we looked at our patients treated at the University of Michigan between 1991 and 2017. And we picked that window because we felt them to be both contemporary over the last 20 to 25 years, but also they had the most complete medical record because of our electronic medical record. And I don't know what it's like where you're practicing, but many of our electronic medical records now across institutions can connect with this feature called Care Everywhere. So even when our out-of-state patients weren't actively following with our clinics, we were able to get interim data from their home centers that allowed us to really have a robust data set to work from, which in a retrospective single institution series, I think matters quite a bit. And I think what you can see from this slide, at least, is that about 1 in 5 of our patients had an underlying genetic syndrome in NF1. And that matters, as you'll see, because I do think this phenotype has implications on treatment outcomes. And we also found that 45% of our patients had mid-aortic syndrome, and a third were coming to us having had a failed intervention performed elsewhere. So we were offering them a remedial secondary surgery. And so this was, in fact, a much more complicated set of patients than had previously been published on from our center. We sought to understand the anatomic location of these lesions, with the majority being these developmental osteal narrowings right here. And this matters, I think. When we look histopathologically, there are some variations. Segmental lesions occurred in about 10%. Mid lesions, or these apple core lesions, about 8%. And I'd say that that's a bias of our center. So I would say that I'm not convinced, and rather most centers that are caring for kids with renovascular hypertension have a different makeup. And they're going to see far more segmental and mid or distal main renal artery pathologies that may in fact respond much more favorably to angioplasty than the osteal lesions. And I think the osteal element is one in which surgical referrals have been more common, and these are more commonly associated with mid-aortic syndrome than the latter, for example. And so because our practice at Michigan was such a heavy surgical referral, I think it just simply biased the phenotype that we were seeing. And so it's important to acknowledge that, I think, when you consider the data and the conclusions we reached. Also, we didn't have a ton of inflammatory arteritis, and that's a completely separate pathology as well, with very different treatment implications. And so I really speak to you with conclusions we made based, again, on this heavy bias toward developmental osteal stenoses and a heavy contingency of syndromic patients and those with mid-aortic syndrome. Bilateral disease was very common. And again, I think this is probably in part because of the mid-aortic patients that so heavily colored our cohort. And about 1 in 5 had a solitary kidney, either because they had an acquired single kidney from prior nephrectomy or a congenital absence of a kidney. But about half of them because one of their kidneys had failed and atrophied from malperfusion. We favor aortic reimplantation, which you can see here, much more than a bypass. And so when we're able to simply amputate this artery off its ostia, we cut rings back to normal artery and reimplant that lower down onto the aorta. That offers a much more quick and simple procedure. It's a single suture line, and your warm ischemia is lower. It also allows us not to take hypogastric artery, but we did perform 50 aortorenal bypasses. You can see that here, and we favor hypogastric arterial conduit simply given the durability associated with such. We found that superficial vein in this location will dilate over time and frankly become aneurysmal. This just shows a cartoon of both of those reconstructive options. And then we performed concurrent aortic revascularization in 64 children, and that was really split evenly between aortic bypass or patch aortoplasty. Now, when we looked at our outcomes in follow-up, the mean follow-up was about 50 months, which is a couple years. But I'll be honest, we had several patients with follow-up almost, out decades or even beyond. And so we learned some pretty important lessons. And I think what's important is that about 20% of our kids needed some operation later in life. And that was either directed at the renal artery or the aorta. Importantly, secondary interventions to preserve primary patency were required in 13%. So 2/3 of those kids needing a reoperation, it was to ensure primary patency, but a third of them, it was essentially to treat an evolving aortic, renal, or mesenteric vascular bed that we didn't treat at the index operation that became clinically evident following that first procedure. So for example, that means we had operated on the right renal at age 5. And at age 10, with recurrent hypertension, it became clear that the other renal now had a disease or a narrowing, or the aorta had narrowed, and we hadn't appreciated that at age 5. And that gives me this kind of concept of an active disease still. And some of our kind of laboratory data is suggesting in some of these kids, there's probably an inflammatory process at play. And we also found that the relative incidence of reoperation was increased in patients with mid-aortic syndrome and neurofibromatosis, and I think that matters. I'd also say that amongst our surgical experiences, we cured hypertension in about 45% of kids, with the similar number of children being improved. 10% didn't have any change in their hypertension, but I'd say these were kids in which we were able to at least salvage renal perfusion, prevent dialysis needs, and or treat, for example, leg symptoms. So it was that one drug or two drug hypertension kid that had leg ischemia and exertional fatigue, and we treated the leg symptoms, and the blood pressure requirement stayed stable. And the other thing I'll propose is that we had no cases of dialysis at the time of this case series, but we have in the interim had one patient require postoperative dialysis that was very transient, and that was somebody who came to us already on dialysis. And then importantly, logistic regression modeling identified younger age at operation and abdominal aortic coarctation to be independent predictors of reoperation. And specifically, as age increased by 1 year, the rate of reoperation decreased by about 10%. We also found that neurofibromatosis was identified by univariate analysis to be negatively associated with hypertension benefit, although probably because this was underpowered, it didn't reach significance with our logistic regression. And finally, multiple ordinal regression modeling identified prior intervention as the single independent factor, predicting that kids undergoing remedial operations were less likely to be cured of their hypertension at 33% in comparison to the other patients in the cohort. I don't want to speak too long on this really extensive table, but I do want to just reference a bit pediatric arterial aneurysms. Some of them are associated, in fact, with renovascular hypertension, and some of them are, in fact, associated with some of the other genetic syndromes that I referenced earlier, like neurofibromatosis specifically. And you can see some of the genetic contributions here. But when you see a child with some type of arterial aneurysm in some type of vascular bed, I think it's important to maintain a really broad differential diagnosis. And importantly, especially in the younger kids with aortoiliac aneurysms, exclude a mycotic source. In the aorta, you've got to think about active inflammatory arteritis and arteritis pictures, including Behçet disease, systemic lupus, Kawasaki's, periarteritis nodosa. These can really yield substantial diffuse aneurysmal pictures. And importantly, these kids respond often to anti-inflammatory treatments. So there's a medical treatment option for some of these patients. And then there are also genetic and traumatic causes, with developmental idiopathic aneurysms falling in kind of a bucket that you've got to exclude all of these other things first before you define it as a developmental aneurysm. The challenge with pediatric aneurysms, because they really are a treatment dilemma, is that their natural history is ill-defined. Frequently, there have been ruptures and or deaths described in large aneurysms, but also in small aneurysms. And when we look at those kids with aortic aneurysms, renal and splanchnic artery involvement, much like the mid-aortic patients, is super common. Additionally, the operative therapy is complex, where you have to consider, again, patient size, what you're going to utilize for a conduit, thinking about future growth potential. And we basically have used the risk of expansion and rupture, the thromboembolic potential, consequences of local soft tissue and nerve compression, and secondary hypertension in cases of renal aneurysm as our indications for treatment in these aneurysms. When we think specifically about pediatric abdominal aortic aneurysm, these etiologies are often very unclear. I'd say the majority of our cases we have attributed to developmental etiologies, frankly, often associated with a mid-aortic picture where this represents a post-stenotic dilation. And I think you can get a really unfavorable consequence of negative vascular remodeling in these post-stenotic lesions because there is something disturbed within the cells that make up that vascular wall, making them probably prone to have degeneration in that area that otherwise would not become aneurysmal, perhaps in a different patient. This is just a picture of a 6-month-old who had a 2-centimeter abdominal aortic aneurysm, and this was associated with an occlusive coarctation. And so we performed an open aneurysmorrhaphy and a primary aortoaortic anastomosis. we reimplanted the visceral vessels, and this is a 7-year post-operative CT imaging showing the reconstruction fully intact. And I use this just as an example that when the aneurysm can be attributed to poststenotic dilation, we often will leave some of the tissue behind. Treating the obstruction allows the rest of the tissue to almost be protected. And so we've plicated aneurysms and done some other things that you would just never consider in children. And so I guess more to that point, aneurysmorrhaphy with an interposition graft versus non-anatomic reconstructions have been used for some of these kids. And I'll share kind of the size threshold that we think about when we're reconstructing newborns. We're using 6 to 10 millimeter grafts, 12 to 14 in young kids, 14 almost to 20 for larger children. And we use graft that's intentionally larger than the native size to facilitate future growth, but it's important that it is not oversized so significantly that you have stagnant laminar flow that leads to the accumulation of mural thrombus. We also favor PTFE in these kids. It's extremely durable. It has a lower likelihood of future calcification, and unlike the woven grafts, will not dilate or degenerate over time. And as I referenced, there's a role for closed aneurysmorrhaphy, especially if the cause of dilation can be eliminated, like the coarctation that I just showed you, because we assume in these cases, and we've shown over time, that the residual wall can remain stable. Now, that aneurysmorrhaphy or closed plication is really contraindicated when there's a really large size or thrombus present in the lumen. And finally, here's a 5-year-old who has a greater than 3 centimeter idiopathic abdominal aortic aneurysm that was treated with resection and primary repair, and kind of a follow-up study suggesting that she had no complications. This is her 13-year surveillance study. So we looked at our experience in treating abdominal aortic aneurysms in infancy and early childhood. It was 11 kids over 12 years. I mean, these are extremely uncommon, and the patients came to us aged 2 weeks to 6 years at the time of surgery. Only 5 were infrarenal, implying that the other half were far more complicated. There was one perioperative death. That was in the 2-week-old who came in with, frankly, profound heart and renal failure at the time of presentation and was probably not a patient to be salvaged. We did identify aortic graft occlusion in 2 kids. One occurred at 1 month, one occurred at 3 years postoperatively. These were in the earlier arm of that experience before I actually had joined the group. And one, in fact, was due to a graft being oversized and that mural thrombus that we talked about, serving as a nidus for more aggressive graft thrombosis. And one of those kids was treated with a thrombolysis procedure and salvaged, and one was just left occluded and frankly had no sequelae related to that over time because it had occluded so late. The remaining children incurred no aortic reconstructive related morbidity or mortality, and we had mean follow-up about 5 years out from those reconstructions. And when we look at the pediatric non-aortic aneurysms, we've had in total 41 children who had 61 aneurysms treated between 1983 and 2015. There was a male predilection. This figure shows kind of the location of all of these aneurysms, and we have got a really nice publication that breaks this down that Dr. Frank Davis published, and it's probably beyond the scope of today's talk for me to get into each territory with independence, but we identified a mean age of about 10 years across the cohort, a mean weight of 31 kilograms. 14 of the kids, so about a third, had multiple aneurysms, and the majority were again, really developmental, about a third being poststenotic, and the arteridities and connective tissue disorders being kind of fewer and further between. These are just some nice pictures, I think, that showcase some of our intra-abdominal aneurysms unrelated to the abdominal aorta. You see the celiac, the renal, and SMA here involved. Here are more peripheral aneurysms related to the common iliac, hypogastric, your fempops, and these are mainly resected with reconstruction via primary anastomosis or typically an interposition bypass. Obviously, the hypogastrics can be coil embolized. And in the central kind of pelvic territory, we'll reconstruct the iliacs with prosthetic, again, because saphenous vein will degenerate. You can use saphenous venous conduit in the extremities for uppers or lowers, but they will degenerate over time and need to be monitored closely with surveillance for aneurysmal degeneration. And then here are some upper extremity axillary, brachial, ulnar, and internal carotid aneurysms as well. When we looked at our experience specifically with the renal aneurysms, and I include this given the renovascular hypertension element of this talk, we had 15 kids with 26 aneurysms, half of them being segmental, and they were treated by a variety of different means. Very rarely was nephrectomy indicated, and we had about a 15% reintervention rate over time, and that's not completely dissimilar to the data I presented from our renovascular cohort. I'll skip this table looking at our splanchnic aneurysm experience. But I do think it's important when we look at all of those visceral aneurysms in the belly that we had no postoperative mortality, no major morbidity, and freedom of reintervention rates that approximated 70% at 3 years. The point being that, that these kids do have very meaningful, durable lives after these procedures. And you've really got to think about what's going to give them the longest term, most durable, best option, I think, when you're selecting treatment options for them. So clinical conclusions from all of this data really are that I don't think kids are little adults, and I don't think I need to share that statement kind of with this audience so much. But surgical reconstructions, as I referenced, just simply must offer durability with acceptable morbidity. These kids have meaningful life expectancy and meaningful quality of life ahead of them. I think that phenotype and our lab data would suggest probably that genotype should drive individualized surgical decision-making and treatment plans. And I'll propose that I've modified my approach in part for some of our complex syndromic kids, especially those with NF1, and I've become far more conservative in managing those children based on our own data. Surveillance is critical. I hope that's been an easy takeaway from these data, and it's important, I think, to leverage a multidisciplinary team. I'd say finally, this is a super complex practice. It requires persistence and optimism, humility and resilience, and frankly, innovation. I know that we can do better. And I want to share a little bit about what we're trying to do as a larger collaborative and to do just that, to do better for these kids. I referenced teams when I started the talk, and I'm going to kind of come back to teams again. And if anybody has read this book, let me know. If you haven't, please consider it. But it's a really great book that qualifies and quantifies the diversity bonus. And that's based on the premise that teams that include cognitive and identity diversity outperform homogeneous groups on complex tasks, yielding a diversity bonus that not only includes improved problem solving, but increased innovation and more accurate predictions. And all of this leads to better performance and better results. Scott Page draws this conclusion from research that's well-founded in economics, in psychology, in computer science, in so many other fields. It's this really compelling mathematical data, really consistent quantitative data that supports this bonus, which occurs not just because people who are different bring different ideas to the table, but importantly, by being exposed to difference changes people, helping them to generate more ideas and to think more deeply about problems. And I think that that matters a lot when we think about a rare disease for patients that are touched by lots of different disciplines. We are going to be stronger working together. And so we did that at the University of Michigan. And I just want to highlight the multidisciplinary team that I helped to expand there during my time, working closely with interventional nephrology, interventional radiology, nephrology, surgery, and other disciplines. We were able to expand shared clinic visits and frankly, global health outreach visits where we would telehealth with multiple providers. We had a monthly case conference where we really dug into deep detail, many referrals. We generated operational enhancements and order algorithms to optimize safety and quality. And importantly, we really focused on team science or innovation with a lens towards genetic and molecular advances, computational flow dynamics, health services research, and clinical research to kind of move the needle. And I'd remiss not to recognize my mentor, Jim Stanley, with the important legacy he's left behind in that practice at Michigan and all that he offered me in his mentorship and training. And Dr. Bobby Beaulieu, who's joined John Eliason at the University of Michigan to help carry on the surgical practice there now that I've left. And these were all of the disciplines we engaged at the C.S. Mott Children's Hospital at the University of Michigan, and I'm now coalescing a similar team at Duke. And importantly, we qualified a vision statement, and I think it includes all of the things you would think a vision statement might include for a clinical program, but we also prioritized laboratory and clinical research, and that was kind of a founding pillar for our collaborative work together, and I think that matters. And I want to highlight Dr. Ganesh, a vascular medicine doctor with whom I partner, and her lab specifically that is really leading all of the basic and molecular and genetic work in this space. I'm going to skip a few things, but I do want to just focus very quickly on some of the genetic lessons that we've learned. And both, we've got a European group and the Boston Children's Group that have qualified genetic variants that have been identified specifically in the mid-aortic space. And importantly, up to 40% of these cases, we think, may have an underlying monogenic cause of disease. Now, we've sequenced our children, and what's been published, at least that I can share, are neurofibromatosis variants, which I'm showing you here. And so we really did a deep dive into this particular genotype, and we identified this image supports kind of the variants of NF1 that we've identified, and I'd suggest that 10 of them are novel variants now in the literature that weren't previously described. And I think this is kind of my one slide of basic science for you that matters. We looked at 122 consecutive pediatric patients with renovascular hypertension, and we've enrolled them both in a clinical database, but also been able to accrue physiologic samples, both in blood, saliva, and operative tissue when available. We found 13 with a concurrent clinical diagnosis of neurofibromatosis. We performed whole exome sequencing for germline variant detection, and then we did RNA-seq analysis of NF1, MAPK pathway genes, and MCP levels. And we performed this RNA-seq analysis specifically in 5 NF1 stenotic renal arteries, as well as control renal and mesenteric arteries from children that had no known vasculopathy or NF1. In 11 unrelated children with sequencing data, I showed you that the figure with 11 genetic variants, of which 10 were novel, having not been previously reported by NOMAD. We found NF1 gene expression shown in this figure from resected dysplastic arterial tissue to be significantly decreased by 5-fold in the NF1 children when compared to donor control tissue here. And then globally, several genes were observed to be differentially expressed in the NF1 renal artery tissue. This is a volcano plot, importantly, that demonstrates differential gene expression, and notably CCL2, which is also known as MCP1. This is an inflammatory marker for tissue injury, and it's significantly upregulated in our NF1 renal arteries when compared to controls. And so importantly, gene enrichment analysis has revealed a significant upregulation in these MAPK related pathways. To validate the activation of the RAS MAPK pathway, phosphorylated ERK expression was assessed by immunohistochemistry on the renal artery sample obtained from a proband that had one of our more severe clinical phenotypes, and importantly, the lowest NF1 transcript expression in the RNA-seq analysis. And the histological findings are shown here. They include really moderate intimal and prominent adventitial thickening, as well as intimal thickening, and cytoplasmic and nuclear immunolabeling for phospho-ERK was 4 to 20-fold higher in the media and the intima of the sample in comparison to control renal arteries. And so we believe from all of this data that the increased level of inflammation and the upregulation of the MAPK pathway may suggest downstream effects of observed NF1 variants in renal artery tissue, particularly of intimal hyperplasia, and that NF1 is associated with a more aggressive adverse vascular remodeling process, which we then translate and hypothesize contributes to the treatment limitations that we're identifying in this patient cohort specifically, which was just presented in our clinical data. Trying to kind of tie those things together. I'm going to skip through, since we started just, I made a little bit of a delay, I'm going to skip through the adult fibromuscular dysplasia slides, and I hope that doesn't upset anybody, but I'll just say that in short, there's a inclination to call these kids pediatric FMD, and we know both genetically and histopathologically that these are discrete diagnoses. I do want to show you this really beautiful slide from our lab because it I think amplifies an earlier message in the talk, but this is a trichrome stain of one of the osteal renal artery lesions, and so collagen is stained blue. And this really shows you nicely the intimal proliferation, this plug of scar tissue. The elastic lamina is often fragmented. Those are those kind of black fibrils here. There's real medial thinning as opposed to adult FMD, where that media is almost hypertrophied. And there's excessive periadventitial elastin, which lends to a lot of elastic recoil, for example, after an angioplasty. But what we've also learned is that these arteries are small. And so this figure shows what a normal arterial diameter angiographically looks like with age, so that y-axis is diameter and the x-axis is age in years. And so this is how an artery will grow if we look at normal arteriographic images. And then these are all pathologic arteries. The extraluminal diameter is shown here across our 23 specimens that we took from 20 kids. And so extraluminally, these are smaller vessels than you would expect. And then when you look at the intraluminal diameter, it's confounded further by that plug. They're tiny, tiny vessels. And acknowledging that small size, along with the elastic hypertrophy and likelihood of recoil, I think it's easy to understand why angioplasty can fail. So our collaborative, if you care for these kids, if you care for this disease, if you're studying it, if you approach these patients and families, please consider joining our collaborative. The website is here at the bottom, and I'll kind of walk you through this. There is a virtual research network that you're able to access, and it allows a few things that we'll talk about. But why did we launch this collaborative? In part for the fact that low disease frequency limits our data. But importantly, the expansion of novel surgical and endovascular techniques have really changed the landscape of pediatric care for these patients. And families are often challenged to balance differing sets of recommendations. We also know that multidisciplinary high volume referral centers of excellence are few and far between. And so access can be limited, and the gold standards for treatment still remain ill-defined. And so we want to do the best that we can for these kids, but we're all, I think, doing the best that we can with the limited data that we have. And so we were able to secure funding from the Taubman Institute at the University of Michigan, Dr. Ganesh and myself. And this award really transformed our work. This was a precision medicine-based award. And the kind of first output from this award culminated in an inaugural and international pediatric symposium that we hosted in 2019 in Ann Arbor. And we really intentionally brought together an inclusive multidisciplinary planning committee from programs like Boston Children's and Sick Kids and Gauche and CHOP in Philadelphia, essentially programs that we knew were caring for these kids with some degree of volume. And we chose to build a program that highlighted best practices in patient care, recent discovery, ongoing research, and this was really the first of its kind to intentionally engage global thought experts caring for these kids. We featured 40 invited guests from more than 15 centers, 6 countries, 12 specialties, and a post-symposium survey importantly revealed that 95% of our attendees supported expanding collaborative research. And from there, our collaborative was forged. Now, here is what kind of the opening site to our website looks like, and you can join now our virtual research network. Our early aim was essentially to do just that, to build a collaborative and prioritize patient-centered outcomes research and comparative effectiveness research around diagnostic and treatment decisions. We did all of that, and we conducted our second international symposium last fall before I left the University of Michigan. We've since been funded with a second round of engagement, and we're now taking our prioritized research questions and pushing forward larger scale multi-center comparative effectiveness research proposals to PCORI. And our membership has now grown. This is an old slide, but we're now well over 200 members, and you can see some of the distribution geographically speaking. And we really are looking to optimize and enhance our international collaborations. And so please, reach out to me anytime if you'd like to talk about this collaborative. And what I'd say is on the public facing website, there are some resources, and there are more resources when you join the virtual research network that are made available to patients and families, clinicians, and researchers. And we've got a newsletter that launches every 6 to 8 months, and opportunities for webinars, education. There's now a growing patient support group, and then research opportunities. And so any new and interim relevant updates in this space are going to be pushed out to our virtual research network patients. The first survey that we launched to our members really sought to capture patient and family perceptions, and we really learned a lot from our patients and families, and I'll qualify just a few takeaway points. And the first is that developmental delays really are common amongst our kids. And I'll say some of these lessons were really I underappreciated. Importantly, 43% of respondents suggested that special education services were being utilized, and 75% utilizing some type of specialized therapy or service. Most of the respondents were highlighting that they already had a pretty comprehensive interdisciplinary treatment team. And importantly, in the United States, many patients were requiring multiple procedures. 43% were driving out of state for treatment, and 43% were flying out of state for treatment. And that's pretty compelling, and I think further highlights the access to care barriers that we continue to hear over and over again from our stakeholders. And those out of state and treatment stays were lengthy, with 50% needing treatment extended beyond 1 to 2 weeks. And finally, I'd say that that our patients reported that when they had a surgical procedural history, they had less pain and fatigue than those without. Those that were diagnosed with disease really early in age, meaning less than 2, reported better informational and emotional support, better social functioning than those that were diagnosed at an older age. And adult patients were unsatisfied with the time it took to receive a diagnosis, indicating more pain and fatigue, worse global health, and worse social functioning than satisfied patients, while the patient proxy reporters perceived a delay in diagnosis and reported worse emotional impact. So we really concluded from that survey data that early diagnosis and treatment optimizes the care of pediatric renovascular hypertension that's experienced by patients and families, further, I think, validating the benefit of multidisciplinary specialty care. And so I'm still convinced that we can do better by working together. We really have lofty long-term goals as a collaborative team. I'll just put them on the slide kind of for your reference, but this work is really moving forward nicely, and I'm excited to understand not just this diagnosis better, but how we can support our patients and their families better. I've got to again credit the Ganesh Lab and all of our funders that have helped this, but importantly, our patients and our families who were such a critical part of our second symposium and will continue to be deeply integrated as partners in our research work moving forward. We'll host our third symposium next fall in Durham, North Carolina, and I envision a hybrid opportunity in which there will be a virtual opportunity for participation. And that's all I have. I think I took up all of the time, so I do apologize for that, but I'm happy to linger and take any questions if you'd like to discuss any of this conceptually. Thank you. I'm trying to unshare my screen, so forgive me.
Thank you, Dr. Coleman. I think that was very comprehensive and gives us a fairly good idea of the work that you're doing. And it is fairly complex, I do agree. Some of the centers in India are doing similar work, though perhaps not the numbers that you quoted. I think Dr. Shivanishan is here. Shivanishan, I thought he was here.
I am there. Can you hear me?
Yeah. So I think you have been doing some good work on renovascular hypertension and pediatric aneurysms,
Yes,
especially the aortic space. You would like to say something?
yes, but our maybe our referral bias, we don't get much of pediatric hypertension. Our patient population mostly in the mid teenage people, and
Okay.
it is mostly Takayas related, inflammatory.
Okay.
Our renovascular in children is very less. Maybe as I said, it is referral bias.
Okay.
We have done few pediatric cases. Currently we have one neurofibromatosis induced bilateral renal aneurysm with stenosis awaiting surgery, 13 years old guy. But other than that, predominantly our mid-diuretics are Takayas related. We don't have much of other pathologies. That was the only thing different from that presentation. Otherwise, very extensive work they are doing. So we cannot reach their number, I think.
Yeah, Dr. Coleman, can you hear me now? Is the audio better?
I can hear you, but whoever was just speaking, the audio was glitchy. It was cutting in and out, and I couldn't understand. And I don't know if you could hear it, and you can just.
So what he said was he deals more with some sort of more of the adult, not much of renovascular hypertension, and a lot of Takayasu's disease. So another thing I found very interesting, yeah. Sorry, you were saying something.
No, you're asking about adult renovascular hypertension and Takayasu's?
No, he was just commenting about his work.
Yeah.
So actually, one of the very interesting things that I found in your talk, you started and ended with themes. And I think
Yeah.
that is really something which is very close to my heart too. And people talk about people working with like-minded people, but I think the diverse teams are the ones which really make a big difference. I totally agree with you there. That is where the real growth occurs.
I think so too. I think especially when you're challenged in a positive way, like constructive challenge by people who think differently about a disease. I've learned so much from our nephrology colleagues that they think about the physiology differently than I ever did. And it seemed much more clear to me when Dr. Stanley trained me as far as what our treatment success metrics look like. And even that has been, further expanded as I've learned more from other disciplines about these patients.
So we do have a pediatric nephrologist in this session, Dr. Mehul Shah, and we work closely with him. Dr. Mehul.
Yes, Dr. Gupta.
Yeah, how did you find the talk, and you have some comments to make or any questions?
No, I think it was a wonderful session by Dr. Coleman, and certainly it's an enormous work which he and our team are doing. And as you mentioned in pediatrics, we have had about 10 children with renovascular hypertension. Most of them have had fibromuscular dysplasia as the cause of their hypertension, and we had 3 children with. In fact, we have 3 children with Takayasu's arthritis. Contributing to renal artery stenosis, and all 3 of them required angioplasty with stent placement in few of them, with significant improvement in their blood pressure control, to the extent that 8 of our 10 children are off the blood pressure medications. And we have had better success with weaning them off the antihypertensives. But yes, I think it's not as vast. We have probably been missing some cases of renovascular hypertension. But I do feel that of late we have been more aggressive in getting the workup for renal artery stenosis as compared to the previous decade. So you, Dr. Coleman, had mentioned that the chances of failure are higher when both angioplasty and stent placement was done. Is that correct, Dr. Coleman? In one of our slides, that about 32% incidence of, if I probably got it correctly, that children who underwent both angioplasty and stent placement did not have as much of a success as compared to those who had only angioplasty. Please correct me.
No, so you're not wrong at all, but I'd say that's a select cohort of patients that have developed recurrent hypertension after their procedure. So they were patients referred to us specifically for surgical revascularization. The lesson learned being that when the angioplasty and stenting fails and the children need a definitive surgical revascularization for salvage, their outcome is blunted, meaning the hypertensive benefits are lessened, and the risk of nephrectomy is higher, especially if a stent has been deployed in a child less than 10. And those were kind of the big takeaways. But again, my bias, and I'd say Anne-Marie Cahill at CHOP, they've got an interventional cardiology team at Boston. I think there are certain lesions that are effectively treated with angioplasty. And so the more kind of multifocal FMD or distal renal segmental lesions that may be more web-like, if you will, I think those are best treated potentially with an angioplasty first. The Takayasu patients 100% are going to benefit from angioplasty first. I think we have to be very cautious with the use of stenting. And I do think there's something to using a team that does this with some frequency, meaning there's a nephrologist on board, even potentially a surgeon on standby in case things fail. One of the challenges I think we felt as a healthcare system in the United States is that by calling pediatric renovascular hypertension, whatever the phenotype, dumping it all in as pediatric FMD, somehow empowers adult proceduralists perhaps to treat the kids like they would an adult. And they're different. I'd also suggest that, again, based on the kind of the scientific data that we're seeing with genetic sequencing, histopathologic data, and RNA-seq data, that a developmental lesion and mid-aortic syndrome are probably really different than a mid to distal renal artery stenosis in isolation. And so just acknowledging that the phenotype of the patient and then the genotype, especially if there's an underlying syndrome, may dictate that treatment options should be considered separately. I do think that matters. Now, Anne-Marie Cahill at CHOP has published on her experience, and I've heard her talk multiple times on their approach to NF1 related osteostenoses and using kind of repeated serial cutting balloon angioplasty. And I will say that her data is getting better over the years. And so certainly as both technological devices and innovative treatment algorithms advance, I think that what we have available to kids now is different, obviously, than it was a decade ago. And this is always going to be a bit of a moving target. But I also think as specific people really dive deep into managing a patient population that's rare, their experience is going to continue, I think, to get improved as they have more and more exposure. And so I do think there are high volume centers that can offer treatments, and there's a role for angioplasty. I personally just am reluctant to offer that first line to reasonable candidates with reasonable risk of a specific age and size with both the mid-aortic syndrome and those osteo lesions, knowing that we can give them often an index procedure with reimplantation, for example, that offers them long-standing durability and perhaps enhanced hypertensive benefits. With that said, we really need a deep phenotyping prospective registry that captures multiple centers so we can understand what's going to be better for children in the long run. And the final thing I'd say is we don't actually have any data right now that optimal medical management, perhaps with 3 drugs, is not as good, for example, as a revascularization. And this is where families are often hearing different things. They're being offered treatments on 1 drug, 2 drugs. They're being offered a catheter-based procedure versus an open surgery. And most of them aren't finished physicians or clinicians, and it's really hard for them to balance recommendations.
Yeah, Dr. Coleman, if you have a few more minutes, there are some more questions. Yeah. So one is, if there is a 13-year-old child with renovascular hypertension and the blood pressure is controlled with 2 drugs, should we wait and plan once the child grows? Or is the patient really going to require intervention at all?
Yeah, I think it's a good question. And I think that it depends on a couple things. And the first is what medications the child's on. And so, for example, if it's a female child and it's an ACE inhibitor or an ARB, those drugs can't be continued during childbirth, for example, or pregnancy. And so I will say there are occasions where we will operate for 2 drugs, and it's generally the preteen, early teen years, especially in female patients, where we know if they get pregnant that either they're going to have their drugs held, we're going to struggle to manage hypertension during pregnancy, and I think there's probably an added risk of preeclampsia, for example. We also are more aggressive in children who have a single kidney. But if you're on 2 drugs and it's like a low dose amlodipine and or a beta blocker, something like that, I think it's perfectly fine to wait. And then the question becomes, if you're going to be able to get the kid off both of those medications, you want to make sure if you're going to offer a procedure that you're going to give them that procedural risk, knowing you're going to get them off drugs or at least reduced. So if you've got really good control on 2 meds, I may never offer surgery, provided the kidneys continue to grow, the cortex isn't thinning, the kidney hasn't stalled in growth, when there's no renal asymmetry, if that makes sense.
Yeah. The other one is, when deciding on revascularization, does the size of the kidney matter? And in a child or in the pediatric age group, how would you sort of determine what is the appropriate size of the kidney? Because adults, it's fairly easy for us to decide, okay, this is a shrunken kidney, and perhaps nephrectomy is the best option. But in children, how would you decide that, okay, this patient we should revascularize, or this particular one we offer a nephrectomy?
Some of it depends, I think, on the timing and how it looks, both by ultrasound and by either angiography or CT angiography. And so if you have a grossly malperfused kidney that's dark, like the one I showed you, small and dark where it's not enhancing, there's no cortical enhancement, your resistive indices are super high, that cortex is super thin, and the function is less than 15 to 20%, that's a kidney that we wouldn't plan to salvage. But for example, the kidney that looked occluded but had late reconstitution by imaging or angiography, that ultrasound suggested the cortex wasn't thinned because this was an acute process. And there had been function, just a few weeks back. And so we opted to salvage that one. I'd say also if the functional contribution is more than 20%, I'd have a hard time just taking that kidney out. And I think most nephrologists within our group would echo that. The final issue is sometimes there's just diffuse dysplasia and you've got multifocal dysplastic disease with skip stenoses that affect first, second, and even third order branches. And those are unreconstructible. So sometimes you simply have unreconstructible disease, in which case the kidney left in place offers more risk to the patient in generating renin production and persistent hypertension than benefit in functional contribution. And if it's early enough in life, the contralateral kidney left behind, especially if it's normal, will hypertrophy and do the work of two pretty consistently.
Yeah. Dr. Tapish, anything from you? Ajay Savlania? Any of the students would like to ask Dr. Coleman something? It's a great opportunity. Yeah, another question that has come up while others think, when you are revascularizing these kidneys, do you use any renal protection strategies like renoplegia, or you sort of just depend on the warm ischemia time or a lower warm ischemia time?
Yeah, that's a great question. So we actually don't use any renal adjuncts. And that's because what I failed to share is some of the technical considerations in these renal revascularizations. And the first is that we really try to, as opposed to some institutions that will do a pretty routine auto transplant for most patients, we're leaving everything in situ and trying not to disturb the collaterals that provide that gland until the time that we're revascularizing. And so these lesions are near occlusive and the kidneys aren't getting a lot of antegrade flow. So that cross clamp time, that warm ischemia time doesn't really matter.
Yeah.
I've not found that ever to be a real challenge. In fact, for the coarctation patients, we'll put a supraceliac cross clamp on the aorta and they don't actually have an ischemia reperfusion event once we restore flow to the lower extremities. And I think, again, it's because the collateral pathways are so well developed. So we've not found it to be necessary, although we certainly try to limit the warm ischemia to about 45 minutes. And if we are going to do an ex vivo reconstruction, like I had shown for that complex aneurysm patient, we will, for those cases, ex vivo, put the kidney on ice. So it stays, the ureter stays attached and we're still kind of in situ, but we'll pack the retroperitoneum with ice. And we'll also flush the kidney with kind of cold heparinized saline, but it's not renoplegia. The other thing that I didn't say, and I'm embarrassed that I didn't, but I do think it's important to share, is the suture lines when we're not using PTFE, but when we're doing an aortorenal bypass with hypogastric or we're reimplanting the renal onto the aorta, all of the suture lines are interrupted.
Yeah.
And it's monofilament suture. And so these are 6, 7, or 8-0 proline sutures, and it's an interrupted suture line. We don't interrupt the PTFE, right? Because the PTFE caliber is going to be the going to set kind of the standard for that lumen.
So another, you discussed about female children and hypertension control and then pregnancy. So if you have a female child with a mid-aortic syndrome, but the blood pressure is well controlled, it's only the lower extremity or the lower body flow that is affected, are they at an increased risk of abortions? And would you sort of revascularize these?
Yeah, that's a hard question because I don't actually know the data and I've thought about it a lot. I actually don't know how to get that data really well. Even from the data we have available to us in kind of large databases in the United States. I'll say a couple things. One, when we look at adult fibromuscular dysplasia patients, that's probably the best group to extrapolate from. We do find a higher incidence of preeclampsia. And so I do think that having renovascular hypertension probably sets the stage for preeclampsia. And I don't think that's necessarily a risk for abortion, spontaneous miscarriage, but probably a risk for pregnancy-related complications. I think the larger concern for these patients is that some of those antihypertensive medications are teratogenic and simply can't be given during pregnancy. And so if you have poorly controlled hypertension during pregnancy, that is a risk to the mom and the baby. And that's where I think for younger women, it is not unreasonable if they are going to want to bear children to think about more proactive revascularization. The other thing I'll propose in some of your Takayasu patients or NF1 patients with mid-aortic syndrome, they can be associated with aneurysms, especially of the renal arteries. And we know that gestation, pregnancy-related hormones and blood flow disturbances and pressure changes increase the risk of aneurysm growth and rupture in the peripartum period. And so that also becomes an indicator for surgery.
That answers your question, Shiva?
Yes, sir. Yes, sir. Just
Yeah.
had a doubt. That's why. Yeah. Thank you.
So anybody else has any comments or questions?
I'm going to put my email in the chat, and I'm also going to put our website for the collaborative in the chat, just for easy reference for all of you. And if I can be a resource to anybody down the road for a patient or other interests, please let me know. And then the other thing I'll just propose is if you have international membership through the Society for Vascular Surgery, and I know Prem, that you do as well, you can share this opportunity with your constituents. We will be having kind of a quarterly pediatric vascular interest versus development group where we will be qualifying certain pediatric vascular pathologies and talking about them at length across our pediatric vascular and then pediatric surgical societies. And so I think that'll be a meaningful virtual platform for engagement, and we'd love to have anybody kind of here join us as that formalizes.
I think as you're leaving, one last question.
Yeah.
So
I'm seeing this right now.
Yeah.
Renal parenchymal disease and a resistive index greater than 0.8 and critical stenosis.
Yeah.
Would I consider revascularization? I think that's going to be in part contingent on a few things. The first would be the blood pressure and how severe it is. And the second would be whether or not the kidney function has, I get a split renal function study with a nuclear medicine study to see what contribution that kidney's making. At least from the adult data, resistive indices greater than 0.8 suggests probably, I bet this patient has cortical thinning and may not have a really optimal outcome from renal revascularization. But I think it's more complicated than just resting on a degree stenosis and a resistive index metric. I think it has to do more with the functional contribution, what the size discrepancy looks like, if there's cortical thinning, and then what's your indication for surgery. I presume hypertensive, in which case I would say you would want, 3 to 4 drug hypertension with poor control. So I don't know if that answers your question. It's a little bit more complicated than that. Parenchymal disease is hard to treat, but sometimes you can get those secondary, tertiary lesions that can be angioplastied, or you can embolize parenchymal parts of the kidney. And so sometimes it's a second order, third order branch that's causing a really focal area of renin production within the upper or lower pole. And it's not wrong to either do an embolization procedure in which you just obliterate and cause that portion of the kidney downstream of the stenosis to sclerose. In some cases, we've done partial nephrectomies. And so if some of the kidney can be salvaged and you think it's, got normal perfusion and it's just an island of kidney that can be addressed, that's another way to kind of tackle that consideration.
Yeah. Okay, so Ajay has one last question. I think you can read that.
Splenic to renal artery bypass in the long term. So I would say that a couple things. Splenorenal and hepatorenal bypasses, I have far more experience with in the adult patients that need to be revascularized. My experience with splenic artery in kids is that it's a pretty fragile, lousy vessel. And we've used it. But I would say that every time we use it, I'm like, man, this sucks. And it does suck because the wall layers, for whatever reason, just don't stay together. And I'm never really happy. And I'm worried about dissections. And so I really hate using the splenic artery in kids. And I don't know why that is. And I also don't know if it's because these kids have some underlying, again, kind of deficit in their the cells that make up their vascular walls. But I've never really loved using the extra anatomic bypasses in kids. It's certainly an option when you're really limited in conduit.
Well, I think that we are ready to close the session. I think thank you so much for taking this session and answering all the questions. I think it's been really educative for all of us. And I do hope many of us will collaborate with you when it comes to dealing with pediatric vascular problems. Let's see. I think we should be able to take it forward. Thank you so much once again. Tapish, anything?
Thank you all.
To say? Well, thank you, Dr. Coleman. I think we'll leave you to carry on with work for today, and call you again another day for another talk.
Sounds good. Thanks, everybody. Have a great day.
Thank you so much. Bye-bye. Have a great day.